Hi everybody. So once again, I'm Dr. Pam DeWilde, your medical director in West Virginia. Right now we're going to talk a little bit about constipation, post-op ileus, and as I mentioned in our respiratory video, treating the abdomen for having an abdomen that's full of a lot of stool in order to maximize respiratory diaphragm excursion. So I will tell you that in all of my practice, I've only had 2 patients that I couldn't make poop, and those patients needed surgery. So if you follow these techniques and you get good at feeling and sensing what's happening in the abdomen, you will make your patients have bowel movements all day long. And it's okay to joke with them about that, right? Everybody poops. I use the word poop. You can use the word stool, whatever you want to be more professional. But patients tend to be a little bit uncomfortable when you contact the abdomen. So I find that sometimes a little bit of humor helps them to kind of simmer down. So the first thing that you're going to do anytime that you approach your patient is first talk to them about what you're doing and the purpose. You're always going to emphasize the anatomy and the attachments and why you're putting your hands where you're putting them. But when you first come up to the patient, you're going to observe whether they're distended, you're going to observe whether they're guarding, their positioning, etc. When you first place your hand on the patient's abdomen, I want you to do so very gently, right? So same as with the respiratory video, you're going to blend your hand into the tissues and you're just going to feel for a few things. First, do you feel that there is a bowel movement? Do you feel like there's gas? Do you feel that the skin is taut? Do you feel like there's an increased fluid, anasarca, etc.? You're going to feel each one of those quadrants very, very gently. So we're not even pushing into the abdomen yet. We're just feeling and observing. You also want to sense whether the breath is moving into the abdomen, right? That's a good sign that that diaphragm is very frozen from the pressure that's moving up into it. Good. So I'm observing what's happening in the patient, and for her sake, I'm not going to say some of it out loud, but we're going to get things moving. So as you do this, you've done your general observation, you've made the patient feel more comfortable that you're coming in with a soft touch. What I want you to do as you're talking to the patient or engaging with the patient is to gently soften your hand into the abdominal tissue, right? And what I mean by that is that you're gently pushing with your palm, very soft and gently, into a deeper zone of the abdomen. You're going to do that in all quadrants. I tend to do that in kind of a wave-like fashion. It tends to be more comfortable for the patient. And what it does is help me identify which quadrants or which areas of the abdomen are full. She along midline is a little bit full, so I would say that there's some things that could be moving there. In this population, the geriatric population, you're not going to worry as much about, well, hopefully you're not worrying about pregnancy at all, but you're also not going to be stressing too much about what the uterus is doing and whether they're having a period or anything like that. But in your younger patients that you may treat, if for some reason they're in that facility, you may want to consider how that's contributing to what you're doing. Even though you're assessing at this point, you're also technically increasing peristalsis while you're moving the abdomen and you're getting deeper into that structure. If you had just come up to this patient and went, I'm going to feel your belly, and went deep into the abdomen, they very often will guard and they'll bring a lot of tension to the abdominal wall and you won't be able to feel those deeper structures. Remember that the ascending and descending colons are retroperitoneal, and so you want to make sure that when you're trying to assess and treat those, that you're reaching a little bit more posteriorly in order to engage with those. So let's get into some techniques. First of all, you have the celiac superior and inferior ganglion that you might remember from medical school that you could treat along the midline. Those ganglia, if you can feel them, very often, we all have different descriptions. I feel like they feel like a slightly watered down jelly bean. And for me, I find that they're not always perfectly midline, so bring your fingers to midline above the belly button. Sometimes with these patients, you have to say, where's your belly button, or look to find the belly button. Bring your fingers to midline and then kind of tilt the tips of your fingers, right? Not the sharp pointing part, but the pads, a little bit laterally so that you can gently engage with where those ganglia may be. This one here is just a little bit more firm in that space. And so you can treat them individually, or you can just treat those ganglia in order to help calm down the sympathetic component here by gently bringing your fingers to midline, sinking into the tissue, right? Feeling back and forth, and then just create tension over that space. You'll find that some people will treat this as a rotary motion where they'll engage with that ganglia and then do a gentle rotary motion. You can do that too. And you just chat up the patient, right? They love to talk about what's happening in their world. They don't often get a physician that's touching them. So engage with those ganglia. The whole point here is that any ganglia, any nerve tissue, when compressed or surrounded by hypertonic tissue, is not able to function appropriately, right? So soften the tissues around those ganglia. All right, what else are we gonna do? So we're gonna get the bowels moving more aggressively. You're gonna start here at the sigmoid colon. So the easiest way to do that is to define the patient's ASIS. Take your hands, if you're on the opposite side of the patient, that's easier. You're gonna fall off of the ASIS underneath that iliac crest here, and you're gonna scoop the tissue toward the belly button. And you're gonna hold. You're just gonna live here, chat, make jokes. And you're gonna hold until you feel a tissue texture change, right? Usually there's a softening, sometimes you'll feel gas move. If you're newer to refreshing your hands, you may not feel anything at all, and that's okay, so just hold it for a few breaths. Then you're gonna move to the lateral side here, right? You're gonna be moving from the sigmoid colon up the descending, across transverse, and down the ascending, and you're gonna do so in this horseshoe-like fashion. If you're short on time, or if you've got a friend with you, right, you can have them reach across the body and also pick up those tissues. Side note, if you have babies at home, this is amazing for colic. And you're just going to lift that bowel, right? So I like to scoop that soft spot between the iliac crest and the ribs. That just makes it easier to get a hold of and get a really good lift. However, with some patients, you can just do so more anteriorly, and that's okay too. Always make sure that you check the areas where you have flexures, right? So with the splenic flexure, kind of take your fingers along this MCP, along the bottom aspect of the rib, grab that area, and then drag your hand down toward the belly button, always toward the belly button. And that's gonna help with that flexure area where you can get a lot of things that are stuck. All right, and so to quicken up this, for the sake of your time, you're gonna do the same for the transverse. You can do that superiorly or inferiorly. You're gonna hit this flexure here, drag that tissue down into the abdomen, and then you can either lift from the side that you're on, or you can go onto the other side of the patient and you can lift the tissues there. Right now I'm just kind of scooping with one hand, using this hand to help lift the bowels. And then always make sure that you get into the ileocecal junction as well. So you're gonna pull that toward the belly button. Once you've done that for the large bowel, you're gonna go to the small bowel, right? Think about the attachment of the mesentery and the attachment of the small bowel. This is the easiest way to treat this. And I jokingly tell my patients, I'm just moving the bowl of Jell-O. I'm softly engaging with the tissues. You do not want to deeply engage. You've got patients, and by deeply I mean you're getting deep in the abdomen, but you're not pressing hard on the tissues. You've got a population of people that are on blood thinners, that have very sensitive tissues, and so you want to meet and match the pressure that the tissues are giving you. Do not push beyond them. But gently roll the belly. The quick version of this is that you're talking to the patient, and as you're talking to the patient, you're really just bringing it all the way around and then ending with this jelly roll, which he has none of, but your patients will. Good, so that is gonna stimulate peristalsis, it's gonna calm down the sympathetic contribution. Anytime you're treating constipation, if possible, you also wanna treat the sacral and the cervical components of that, right? The parasympathetic contributions, so you can treat the cervicals. You can treat the sacrum non-directly, right? I treat a lot of patients in the hospital and in the SNF environment as well. You never know what you're gonna find under there, so you may not want to get directly on the sacrum from underneath the patient, but you can treat that through the pelvis. So let's do this. Let's review one little way to treat the sacrum in the supine position that will help get that moving. And then that'll help round out your constipation protocol. All right, so one of the things that I talked about was making sure that the sacrum is moving for the sake of improving the parasympathetic contribution to the bowels, right? So this is also difficult in patients that are seated or patients that are in the supine position. So I'm going to show you a very gentle muscle energy technique that helps to move the sacrum, or at least free the sacrum from the sacroiliac junction restriction. If patients are unable to move the lower extremity, I'll show you a modification for that. Okay, so if they can engage, this is a very simple muscle energy. You're going to keep the legs extended. You're going to gently cross one ankle over the other, and you're going to hold the ankle and tell the patient to push you away with their ankle. Now, 90% of them are going to bend their knee and try to pull you toward them. You want absolutely no flexion of the knee. And because many of these patients have bad knees, you don't want aggressive amounts of tension or aggressive amounts of pushing. So have them gently push you with their ankle. The force should be coming from that hip. And what this does is help to disengage that SI joint. So what I would like you to do is take this ankle and gently push me away. That's one way to do it. However, so she's pushing me this way. This is why we do this, right? Exactly, yes. Yes. Now, if you say, push me away like I'm trying to take your money, they get it right every single time. Good, let that go, right? So 3 to 5 seconds, bring them into a new barrier. She's doing a great job of keeping the leg low. Do not do this from up here. It will not engage the correct musculature. Go ahead and push. You feel that in your low back? Good. So this does a great job of also treating that L5 lumbar connection, good, to the sacroiliac, or to the sacrum. And it's helping to gap the SI joint. So you would do that on both sides, right? So I would bring her other leg over, and I'd have her do the same thing and push out. I would do that 3 to 5 times or until I felt like we had achieved a good change. Now, if the patient does this and they complain of too much pain, usually one side is worse than the other, just reassure them that that discomfort is an indication that you're hitting the right spot. Also, tell them to just calm down the push, right? They barely need to engage with those muscle fibers to have that actin and myosin unlatch and stretch, okay? So you don't need massive amounts of push. One other thing to note, when you are doing your initial assessment and treatment of the abdomen for this for constipation post-ileus, whatever you're doing that for, or respiratory function, one of the things that can help to alleviate some of their discomfort while you're doing that pressure in the abdomen is to just have them bend their knees. So if they're capable of doing so, have them bend their knees while you do that abdominal treatment. It can be more comfortable. If they're not capable of doing so and you have a friend, you can have your friend bend the knees for them, or you can just soften your touch. The only other thing I'd add is that anytime you are addressing the abdomen, you should also be doing an OA release. Remember about the vagus contributions to that space. And when the patient doesn't understand why you're touching their neck because you're treating them for constipation, you're going to fix that by using your osteopathic mind and your knowledge of anatomy to talk them through that process. And that should be helpful. That'll get all of your patients pooping within a few hours. And if they don't, they need more intervention.